So in bacterial uveitis, the first one is tuberculosis, which is a chronic granulomatous infection usually caused in humans by Mycobacterium tuberculosis. It's primarily a pulmonary disease but may spread by the bloodstream to the other sites. Ocular involvement commonly occurs without clinically overt systemic disease. Immune deficiency is a risk factor when atypical mycobacteria such as AVM may cause a disease. So it primarily affects the lungs. There is necrotizing granulomas and secondary ocular tuberculosis. Uveitis is the most common form. Most common opportunistic infection in AIDS. So there is mainly four types of dissemination. One is hematogenous dissemination. There is formation of primary complex, post-primary reactivation of lung lesion, retinal pigment epithelium involved in phagocytosis. Ocular manifestation. In ocular, there is adnexal anterior segment, posterior segment, neuro-ophthalmic and drug-related ocular toxicity. So in adnexal, there is tubercular dacroretinitis, in which there is inflammation of the main or accessory lacrimal glands, as shown in this picture. There will be pain, watering. The definitive diagnosis is by biopsy. It may involve the lateral rectus or superior rectus or levator muscle complex. So it may involve the eyelids known as lupus vulgaris. These are reddish brown eyelid nodules as shown in the picture, unilateral, insidious. These are painless, soft, reddish brown nodules. They progress to a red plaque. They are often accompanied by lymphadenopathy, may progress to ulcers, scarring, and squamous cell carcinoma. So these are known as lupus vulgaris. Eyelid tuberculous granuloma. These are unilateral, insidious. These are violet brown, non-tender, mobile nodule accompanied by lymphadenopathy, and they can also ulcerate. Complication is trichiasis and entropion. In the anterior segment, it can cause conjunctivitis, conjunctival granuloma, placental keratoconjunctivitis, tuberculous scleritis, interstitial scleritis, and iridocyclitis. This is tuberculous conjunctivitis. It may be unilateral, primary, or bilateral secondary. There will be mucoid discharge, there will be late edema, chemosis. These are small painless nodules on tarsal conjunctiva and fornix. Large follicles may ulcerate. These are conjunctival granuloma caused by TB due to type 4 hypersensitivity reaction. They can undergo calcification or inflammation and irreversible damage to ocular tissues. It also cause keratitis, scleritis, ulceration. TB can also cause placental keratoconjunctivitis due to delayed hypersensitivity reaction, which may be bilateral and more common in children. TB can also cause tuberculous scleritis, which is due to direct spread from a local conjunctival lesion or via hematogenous spread. It can also cause interstitial keratitis, which is inflammation of the corneal stroma. Focal, multifocal, or diffuse stromal opicities or an immune ring may be there, associated with stromal edema and anterior chamber reaction. Interior uveitis is common and is usually granulomatous. Iris nodule may be present and broad posterior synecdoche may be formed. Other complications are band-shaped keratopathy, annular ring synecdoche, iris bombi, occlusion pupillae, cataract, glaucoma, and vitritis. It can also cause intermediate uveitis. It includes vitritis, posterior cyclitis, sparse planitis, snowball opicities. These are the snowballs opicities. Also, it can cause snow banking. Snow banking is gray, white, fibrous exudate plaques. Symptoms will be floaters, blurred vision, pain, photophobia, red eye. It can also lead to cystoid macular edema, epiretinal membrane formation, complicated cataract, neovascularization, RD, and vitreous hemorrhage. Posterior segment, it can cause choroid tubercle, tuberculomas, serpiginous-like choroiditis, subretinal abscess, choroid tubercles, and tuberculoma. These are focal elevated dome-shaped lesions that may be unilateral or bilateral and solitary or multiple. Extensive infiltration may occur in individuals with AIDS. A large abscess-like tubercle is termed as tuberculoma. Choroiditis independent of tubercles, typically multifocal and is centrifugally spreading serpiginous pattern serpiginide, known as serpiginide, has increasingly been recognized. Choroiditis that tracks retinal vessels may have reasonably specificity for TB. Retinal vasculitis is preferentially venous. Retinal hemorrhage are common vascular occlusion with extensive ischemia, and pre-retinal or disc neovascularization can occur. It is hypothesized that at least some cases of Eales disease represent a hypersensitivity reaction to TB. So, investigations, diagnosis is often made clinically considering evidence of previous TB exposure and other negative investigations. A tuberculin skin test may show a positive result within 48 hours. Systemic assessment by an appropriate specialist. Newer investigation includes sputum testing with PCR and interferon gamma release assay. Blood test. This is approximately as sensitive as skin testing, 80% in active disease, but has the advantage of being independent of previous BCG vaccination. HIV status must be determined. Chest X-ray, CT, positron emission tomography are among other tests. Ocular test, aqueous filter sampling. They rarely yields demonstrable bacilli. PCR is highly specific but variable sensitivity. OCT is useful for macular evaluation. FA may be helpful in establishing whether choroiditis is active, as well as confirming pre-retinal neovascularization and demonstrating ischemia. FAF allows active staging, lesions becoming progressively hypoautofluorescent with healing. Treatment is prolonged multi-drug therapy. Initially 4 drugs. It should be prescribed and monitored by a specialist. In TB management, if ethambutol is used, monitoring for optic neuropathy should take place. So for ethambutol, optic neuropathy should take place. Rifabutin can cause anterior uveitis. Non-adherence to treatment is common. Treatment with TB medication in patients with uveitis associated with latent TB halves the risk of uveitis recurrence and delays the onset of first recurrence. Topical and systemic steroids may be used concomitantly to reduce inflammation and reduce damage, particularly in the early weeks of treatment, when they may retard paradoxical worsening of the fundus appearance. Laser may be applied to ischemic retina to treat pre-retinal neovascularization.